And so in this final session, I'm joined by the co-chairs of the forum, of the Preparedness Forum at the National Academies, Dan Hanfling and Suzette McKinney. And then we've invited Matt to come back and join us as a representative of the Planning Committee. Suzette is a principal and director of life sciences at, I apologize. Sterling Bay, thank you. Yeah. And Dan is vice president for technical staff at Incatel. And they both are the co-chairs of the Preparedness Forum who have sponsored this webinar series. So I know that Suzette has to leave us at the top of the hour. So Suzette, the floor is yours for any comments.
Great. Thank you, Eric, and good afternoon, everyone. So I think in the interest of time, our colleagues this morning have highlighted a number of operational-based suggestions for where we could improve our work with the crisis standards of care. So with my comments, I think I will try to speak a little bit more high level and offer some suggestions for opportunities that I see with regards to some of the planning tools that we have available to us for crisis standards of care planning. I will say, I think it was mentioned earlier, a number of examples where we've had opportunities to gain experience from crisis standards of care, most notably, or with crisis standards of care, I should say, most notably Hurricane Katrina, our Ebola response, and of course, our COVID-19 response. I think, you know, as a country and as public health and healthcare planning partners and policy partners, we really have a great opportunity at this point to do a reevaluation of the crisis standards of care framework to ensure that all of the necessary components are present within the framework, those that have been informed by our response to COVID-19. I think that there's also an opportunity for us to provide recommendations for how to best implement the planning framework. I spent a considerable amount of time during my years at the Chicago Department of Public Health, working in collaboration with our partners at the Illinois Department of Public Health. And it took us quite some time to figure out how we would implement the crisis standards of care framework for our city and for our state jurisdictions. And so again, I do think that there is great opportunity on a more national level for us to identify how best to implement that planning, utilizing the framework and ensuring that all of the necessary partners who have a role to play in that planning framework are included and are at the table and understand that implementation strategy as well. I also believe that there are opportunities to ensure that our healthcare workers are well trained on the indicators and triggers. Certainly COVID-19 took us by surprise, but I think that there were moments throughout the response, especially in the beginning of the response, where we could have anticipated much sooner some of those things that would have impacted our healthcare systems and our ability to implement some of the strategies and the planning frameworks that we had done at the public health level. During Tenor's presentation this morning, she talked about recognizing nurses as talent and a scarce resource. And I wanted to amplify that point that she made, but also add to that, recognizing other healthcare workers as a scarce resource, because I think that there are opportunities for ongoing development for both nurses and other healthcare workers, particularly around the crisis standards of care, indicators and triggers. Another aspect that we have talked about for a number of years, or at least has been suggested for a number of years, but we haven't yet had the opportunity to dedicate time to working on it, I believe, is an opportunity for a toolkit or framework for elected officials. Certainly, the size and scope of the COVID-19 pandemic had our elected officials much more involved than with previous emergency responses. But I think there is a great opportunity and also great impetus for an elected officials toolkit at this point. I would certainly be interested to hear from my colleague Dan Handling on his thoughts with regards to that level of a toolkit. I believe there's an opportunity for us to develop a communications framework that integrates messaging from all levels of government to ensure that as a whole of government enterprise, we are providing the most up-to-date, well-coordinated, and succinct information to the American public. I agree with the suggestion that was made earlier today around a federal coordinating body. And I think a federal coordinating body would be an ideal type of entity to assist us in not just developing a whole of government communications framework, but also to assist us in implementing such a framework should it become necessary again in the future. And then finally, I was reminded of the pandemic influenza exercises of old, if you will, when CDC used to conduct national level pandemic influenza exercises with specific jurisdictions to assist them in exercising their plans, measuring the effectiveness of their plans, and then evaluating a modification of those plans. I think we have a lot of opportunity at this point to conduct multi-level government and multi-jurisdictional exercises specifically around crisis standards of care plans so that we can both measure those plans at the state and local level and identify areas of improvements for those state and local level CSC plans. And with that, that concludes my comments. Thank you, Eric.
Thank you, Suzette. Great comments, and sorry you have to leave us early. Matt, you get the next word. And so I have a question for you, but I'm gonna let you say whatever you have to say first, and then I'll hit you with the question.
Well, I'll just say two things here. One about things that I worried about before and I now worry about differently. And one was coming out of the Ebola experience and to some extent coming out of the SARS experience. I was worried that politicians would overreact to an infectious disease threat and overutilize public health police powers in ways that might actually be counterproductive and that could, stoke public panic, or that could I'm sure you all remember the, nurse who was put in quarantine after coming back from a stint in Liberia. And most of us in public health thought that was really an overreach of the public health police power and might actually be counterproductive. And I worry about that differently now, because I think what we're seeing is, for similar sort of political calculations, politicians don't always want to do what they actually need to do. And so the role of the public health and medical enterprise in serving as a counterweight to political considerations, I think is different than I had anticipated it to be. I thought we would have to hold politicians back from overreacting. And instead, we're having to push them forward and say, look, it's time, man. We're already doing this. So that's number one. And the second thing that I worry about differently is I had done a lot of work prior on the duty to treat of health professionals, the responsibility to show up in the face of personal risk. And early in the pandemic, at least, that was not a problem. Everyone showed up for work. People showed up for work who were planning to retire. They came back. Right? Everyone, volunteerism, collegiality, coherence, we had it all. And so that issue was not a problem. And I had thought, if we want people to practice in these environments, we're going to have to give them legal protections. Turned out that wasn't true. People showed up despite not having protections for the dangerous and difficult work they had to do. But we're now, over 18 months in, and people are burning out and retiring. And it turns out that you can stretch people, but only so far before they break. And so the duty to treat conversation for me has changed to how do we support people to maintain their resilience. And I've started thinking more about how do we encourage the rest of the public to feel like they have some duties too. Because that's really where the problems are now. It's not the professional duty to treat that has failed us. It's the sense within the public that they have anything to do with trying to control this pandemic. And again, that's a broad overstatement because 90% of the public is on board. But unfortunately, that 10 to 20% is really causing an enormous amount of harm.
Great points. So the question I wanted to ask you is actually a merger of two questions that came in from the audience. And they're related to the issue of, is it possible, we've talked about the different ways in which we can think ethically about the pandemic and about allocation and about triage. And one of the questioners suggests that there are many in the hospital communities, many ethicists in hospitals who aren't really engaged in the national conversation and approach the question from different, have made different judgments. And so the question is, do we think it's possible to have a national consensus on the ethical framework for crisis standards of care?
I'll just say yes, because I want Dan to have plenty of time as well. I think it is possible insofar as it's possible for anything to achieve consensus in our extremely variable community of the United States, but we do hold some core values in common. And I think that questions around the core principles of crisis standards of care, things like trying not to have the bedside team making decisions between their patients. I think there are core aspects of this that that there's wide consensus on. And that's probably, as far as we can get, but good enough that if we could actually get over some of the implementation challenges, that we could do a much more coherent job of implementing crisis standards of care nationally.
Thank you. And on that hopeful note, I'm going to turn it over to Dan.
Yeah, thanks, Eric. Wow, what a wonderful conversation over the last 2 hours. I mean, there's so many things to really pick up on. So first, I'll just start, Eric, by thanking you for doing a phenomenal job in leading this series, and to the entire planning committee, who each of you have done a phenomenal job in bringing forth lots of new perspectives and really important points that have been made over the last 6 weeks or however long it's been going on. And, my partner in writing, John Hick, who couldn't join us today, I also want to thank John, although he's not here today, has been such a intellectual force helping to drive these concepts forward. So with the thanks out of the way, a few reflections. First, never in a million years did I think that in the greatest crisis of our times that we would see an erosion of public health authority, that we'd see an erosion of trust in the healthcare workforce, sort of writ large, that we would see attacks on healthcare workers, based on, the absolute, horrible positions that they were put in to have to make allocation decisions or to have to make access to care decisions. And I also never thought in a million years that we'd have a level of political dysfunction that really kind of hampered our ability to put in place the kind of response that really was required. So with that said, as sort of the context in which, I have viewed this crisis, let me say a few things first about the framework, and then to conclude sort of a few steps that I think would be worth considering going forward. So with regards to the framework, for the most part, I think it holds. I think we got it mostly right. Of course, I'm biased, so I will grant the audience that recognition right up front. But I think that we recognize that there's a duty to plan and a duty to prepare, and there's a duty to steward resources. And we all knew, those of us who worked on this, and all of you on the planning committee and many of you in the audience, that it was always a matter of when, not if, right? It's not if, but when. We knew it was going to happen. And indeed, we were proven right. And I think, as Anuj said earlier, and as we've been saying sort of in the context of the work that I've been doing, we live in an age of epidemics now. I mean, this was the third coronavirus outbreak in the last 17 years. We are going to see more crises like these. And so this is our opportunity to make improvements that are needed. I want to pick up on a point, Matt, that you made towards the tail end of your comments, which you and I have been discoursing on mostly over email over the last couple of months. And that is this notion of engagement, what I would say engagement at all levels, and putting a sort of an ethical frame on it, the concept of reciprocity. Ask not what your country can do for you, ask what you can do for your country, is, sort of the telling words on this, the 58th anniversary of the Kennedy assassination. I think the telling words that must be brought forward in the context of national crisis. And when I look back on the ethical framework, we focused a lot on accountability. As Suzette noted, a lot of our original work was driven by the searing testimonials that we saw coming out of New Orleans after Katrina. And so we felt it was important that the government be accountable to its people, but the people have to be accountable to themselves and to the community. I think that notion of reciprocity is really important. We heard from our legal experts about, the fact that the lack of preparedness ultimately equates to liability, and we need to continue to focus on that important element of planning and preparedness. Situational awareness, I think, became a critical, important element here. We always recognized that from the very early meetings of our crisis standards of care committees. And load balancing really became sort of the operative phrase for figuring out how to get the right patients to the right place in the right time with the right resources. And we're hamstrung right now. We don't have an integrated national data infrastructure. CDC is engaging in modernization of its public health infrastructure, but we have a long way to go, and that has really got to be prioritized. And I would add to that, since we're on the sort of the tech focus, the point that Tenor made earlier today, which is technology is a force multiplier. We have the opportunity really to deliver on capabilities that only a few short years ago were only, something available in the movies or for science fiction. But with capabilities around remote patient monitoring, with telehealth, telemedicine, with AI, and the opportunity to really look at large data sets, we can be smarter in the way that we deliver care. And I think that's got to be a top priority as well. And with that, suffice it to say, our quantitative measures, i.e. SOFA, are unfulfilling. It doesn't work. And we need to move well beyond that. And I just attended a meeting at the end of last week in which SOFA sort of figured prominently in one state's plan for making plans for resource allocation going forward. We need to move beyond that. And then I think it's important to recognize sort of when do we declare crisis. I think it's been made clear. This happens, at the bedside, and we really need to think about how do we shift that arrow to the left, and what does that mean? And we only do so with good situational awareness. So I'm crunched for time. Like Matt, I could talk for an hour, but there are a few, I'm going to give you 4 key things that I think we should focus on. One is that we need better, broader coordination and understanding between the bedside and the boardroom. I heard that over and over again, and that is critically important. This is an all of healthcare entity engagement requirement, and so we need to figure out how to bridge that divide. To Suzette's point, she's heard me talk about an elected officials toolkit for probably the last 10 years. We need buy-in from the political class. They need to understand what is happening, and they need to be active participants in these discussions going forward. Number three, I think we need to do a better job of engaging the provider community. I think that was made over and over again. You know, for me, that was sort of the big loss. We put provider engagement as one of the key fundamental steps to getting towards crisis standards of care, and we never were really able to bring that across the goal line. And then finally, I think, as has been made very clear and very eloquently by Monica and others over the span of the last 6 weeks, we've got to better address the health equity issues. You know, COVID unmasked structural racism in our healthcare delivery capabilities, and as a nation, we can do better. So, you know, it's hard to distill into 5 minutes what is essentially 2 decades of work and 6 weeks of phenomenal conversation. But I did my best, and I want to thank you again, Eric, for helping to lead this workshop. Appreciate it.
Thank you, Dan.